All right, good afternoon, everyone. I'm Michael Liu. I'm the Dean of the School of Public Health at UC Berkeley, and I want to welcome you all to our virtual town hall on outbreaks, what you need to know about COVID, Mpox, bird flu, valley fever, and other emergent public health threats. Our goal is to provide our communities with the most up-to-date, science-based, and trustworthy information to keep you safe and healthy. And we have assembled a truly extraordinary panel of world-class scientists and clinicians to do just that. So let me start by introducing our panel. On our panel today is Dr. Peter Ching Hong, Professor of Medicine and Associate Dean for Regional Campuses at UCSF. Dr. Jay Graham, Associate Professor of Environmental Health Sciences at Berkeley Public Health. Dr. Eva Harris, Professor and Chair of Infectious Diseases and Vaccinology at Berkeley Public Health. Dr. Sandy McCoy, Professor of Epidemiology at Berkeley Public Health. Dr. Sarah Stanley, Associate Professor of Immunology and Molecular Medicine with joint appointment in Infectious Diseases and Vaccinology at Berkeley Public Health. And Dr. John Schwartzberg, Clinical Professor Emeritus, Infectious Diseases and Vaccinology, Berkeley Public Health. Now, we've received dozens and dozens of questions in advance, so let me start with those. If you have additional questions that we haven't answered, please do write them in Q&A, and we will try to get to as many of them as we can. So let's go ahead and get started. And the first question I will address to Peter. Peter, many people haven't paid much attention to COVID for some time. Can you catch us up on what's going on with COVID and how worried should we be this coming fall and winter?
Thanks, Michael, and happy Moon Cake Festival.
Right.
This is my banana moon cake. It's very modern. So in terms of COVID, we've had a very protracted season in California, I think longer than most places in the country, but more than half of the states are now exhibiting declines. But a decline doesn't mean there's no COVID. In fact, we went from very high to high in California, but things are slowing down as evidenced by hospital admissions now in UCSF, probably less than 10, as opposed to 100 during the peak in last winter. In terms of variants, flirt variants, fluke or diffluke variants, those are very transmissible. But in terms of the winter, I think all eyes on Europe now because there's a new kid in the block called XEC, which is a hybrid between some of the currently circulating variants. It's said to be even more transmissible. So what does it mean for winter? We have a big force field now, but in winter, I think people really need their vaccinations, particularly vulnerable populations.
Okay, thank you. Speaking of vaccination, John, the FDA just approved 3 new COVID vaccines a few weeks ago, Moderna, Pfizer, and Novavax. How are they different, and which one would you recommend?
I would recommend whatever anybody will get. I don't have any strong feelings about one or the other. I think if somebody has had really a particularly bad reaction to one of the mRNA vaccines, Moderna or Pfizer, then try Novavax this time. Novavax seems to cause a little less reaction immediately than the others, so that may be an alternative. Otherwise, I really don't have strong feelings about one or the other. In terms of what's available, they're all available, although interestingly, Novavax doesn't do much marketing, so we don't hear about it as much. But it should be in the pharmacies now, although I've talked to people who say they're having trouble finding it. If you are having trouble finding it, contact the county health department, and they usually can give you some information about who has the vaccine for you. Pfizer and Moderna are plentiful. And finally, is it free? Yeah, it's free if you have insurance or if you have Medi-Cal and Medicare, it will be paid for. But there are a lot of people who don't fall into those categories of private insurance, Medicare or Medi-Cal. And they should contact their local health department because the government has funds through the Health Sources and Resources and Services Administration, HRSA, So everybody should be able to get this without any cost.
Great. Thank you so much, John. Peter, back to you. What's the latest public health guidance for masking, testing, and isolation for COVID?
Great question, Michael. I would first start with testing because you have to test first to know what you have before you go through the other steps. Most Americans, or many Americans, are not testing anymore, but it's really crucial to think about that. The government is providing free testing kits for the winter. In terms of isolation, 24 hours, no fevers, feeling better, you can go out into the world. But going out in the world means that you still have responsibility to wear a mask, and I think the mask gets lost in all of this for at least 5 days. If you live with somebody who's vulnerable at home, you might want to test before you take the mask off at home. And after 5 days, it should be fine for most people. So those are basically the updated guidance. I would say in the hospital, it's very interesting how things have evolved. In November, we're going to start mandatory masking for everyone. And we always mask if a patient requests it, or actually we've given new guidance to ask someone if they'd be more comfortable with a mask. Although personally, I carry my mask around still in the hospital.
And Peter, what's the latest recommendation in terms of who should take Paxlovid after a positive test?
So I would divide that into the shoulds and the coulds. The shoulds are definitely those who are older than 65. And I put an exclamation point for those who are older than 65 who haven't gotten a vaccine in the last year or so. These are the people I'm seeing in the hospital. In terms of the coulds, in general, somebody older than 50, particularly if they have comorbidities, we've kind of shied away from giving everyone Paxlovid, but I'm not, someone who is, arguing with somebody if they really want it, because it's relatively pretty benign. You have to check for drug interactions. I always tell patients to make a Paxlovid plan. So before you get sick, to really figure out where you're going to get it, do you have drug interactions? And I would say that probably about 10% of those who are eligible are getting Paxlovid, and that's why I'm still seeing patients in the hospital.
Thank you. Hey, John, back to you. What's the latest on long COVID? Do we know why some people get long COVID and others don't? And what are some of the best ways to prevent long COVID?
Well, we finally have a definition. The National Academy of Science not too long ago came out with a definitive definition of long COVID. And any chronic condition that occurs after a SARS-CoV-2 infection, present for at least 3 months, it can be continuous or relapsing. It can be progressive or not. So 3 months really after you've had COVID, if you're developing long COVID symptoms or you've had long COVID symptoms, are the symptoms have just continued after your acute infection, that's long COVID. And it's a lot of people, Michael. You're talking about probably about 400 million people have had or have long COVID here in the United States. And 7 to 10% of people with long COVID aren't fully recovered at 2 years. So this is a serious public health problem and a terrible problem for individuals. And a lot of folks with long COVID, estimated about 10%, really can't be employed any longer. So again, a big problem. Who's at risk? Women, for reasons that aren't completely clear. Hispanic and Latino people are at higher risk. That may be related to another condition, and that is low socioeconomic status or lower socioeconomic status for many people, health inequities, that is. People who've had a bad case of COVID, a more severe case of COVID, you're more likely to get long COVID. People who have health conditions and are older, especially people 65 and over, are at greater risk. And finally, people who haven't been vaccinated. In terms of what causes it, there are lots of ideas. Some of them have more evidence than others, like fragments of virus remaining in your body, or immune system dysregulation, inflammation in blood circulation problems, or a microbiome imbalance. Those tend to be some of the leading ones that we think about, but we really don't know. It's unlikely that there's one cause for long COVID. And unfortunately, there's no clear treatment if you have long COVID. A recent study using Paxlovid in people with long COVID was not encouraging, but we still need more studies along those lines. Prevention is a little more, there's a little more interesting and positive data there. If you get vaccinated, the data is pretty compelling that it reduces your risk for long COVID or the severity of long COVID. There's been some tantalizing studies with metformin, a couple of them reasonably designed, that suggest it would reduce the risk of long COVID. We need more data before we could really recommend that. And finally, Paxlovid. If you take Paxlovid for the acute disease, there's pretty good data that it reduces your risk of long COVID.
Thank you, John. John, let's pivot to talk about the flu. How can you tell whether you have COVID, flu, or just the common cold? And what's the best time to get the flu shot this year? And can I get it with my COVID shot?
So I can give pithy answers to all three of those questions. In terms of what can you tell the difference between COVID, flu, or the common cold? No. You need a diagnostic test to tell you which of those. COVID can cause asymptomatic infections in up to 30% of people. So you can have COVID and transmit it and be asymptomatic or pre-symptomatic. COVID and influenza look very similarly. And a lot of times COVID and sometimes the flu present just like the common cold. So you can't really tell. And I think people need to recognize that when they say, oh, it just must be a cold because I just have the sniffles. In terms of what's the best time to get the flu shot, I think the best time is sometime in October. You lose anywhere from 2 to about 12% of the efficacy of the vaccine every month after you've gotten it. So if you get it too soon, then by the time influenza comes, at least in force, which is typically after Thanksgiving, especially in January and early February, you're going to not have the same efficacy as if you got it closer to those times. So a good time would be October. I'm planning on getting mine sometime toward the middle or the end of October, unless we hear that there's an early flu season, and there's no indication so far about that. And finally, can I get the COVID vaccine along with the flu vaccine? You've got 2 arms, so you could get 1 in each arm. So yes, the answer is yes. You may have a little bit more in terms of side effects, but studies have shown that there's nothing more risky than that. Just be aware that if you go into the pharmacy to get your COVID shot, they may push you to say, well, do you want your flu shot right now? And again, I think it's a little early for that.
All right, and while you're on the roll, John, let's talk about RSV. So what is it, and who should get the RSV vaccine?
Well, there's 3 really important respiratory viral infections that occur that we're facing in the coming months. COVID, which we face all year round, but RSV and influenza. RSV is probably not as well known by the general public because flu and COVID get a lot more press, but it's responsible in adults for somewhere between 60 and 160,000 hospitalizations every year and 6 and 10,000 deaths in adults 65 and over. And in children less than 5, somewhere between 60 and 80,000 kids get hospitalized every year with 100 to 300 deaths. So it's a really important viral infection of the respiratory tree. There's beginning last year, we had the vaccine, which is really a major advance from a public health standpoint. Who should get it? If you're 75 and over, you should get it. If you got it last year, it's still covering you this year, so you don't need it again. If you're 60 to 75 and you have some underlying conditions, I would urge people to get it. All infants whose moms didn't get the RSV vaccine during pregnancy, those children should get the vaccine. Or some children at high risk, 8 to 19 months, should also get it. And finally, there's also a monoclonal antibody for children whose moms weren't vaccinated that would be available during the RSV season, which begins in November and ends typically in March. Your last question, I think, Michael, was about vaccines. Which ones are there? There are 3 vaccines that are available. One's by GSK, another's by Pfizer, and one's the new mRNA vaccine, Mremsivia. The Mremsivia and the Pfizer vaccine and the GSK can all be given for people 60 and over. As I had mentioned, 75 and over for everybody, 60 to 75 for people with underlying conditions. And the GSK vaccine is the one that's approved for pregnant women.
Speaking of pregnant women, Peter, should all pregnant women get the RSV vaccine, or is it just kind of during a certain time of the year? Can they get at the same time as they get all the other kind of vaccines recommended for pregnancy, which include COVID, flu, Tdap, and are they safe for the fetus?
Yeah, so amplifying what John just said, for pregnant people, 32 to 36 weeks is the recommended time period during the RSV season. And the 36 weeks and not 38 weeks is interesting. And that's because there was a signal for maybe a little bit of preterm births and people who got it late. So to, until more data is obtained, that's why the 36 weeks is there. But, when I talk to people, I always ask that, you don't get it just before the C-section because, again, the worth of the vaccine is to create antibodies, maternal antibodies, and then transfer to the developing fetus. So if you just get it right before, it doesn't really make as much a difference. So the recommendation is if the mom didn't get it, like Dr. Schwartzberg said, you have the monoclonal antibody that the baby can get. But it's really important to figure out the timing. It's very safe. You can get it all at the same time. And, I have no problems in recommending it, particularly because it always causes so much distress in moms, parents, families for the newborn kid who has difficulty breathing.
Thank you, Peter. John, let me come back to you and let's talk about bird flu, which has also been in the news. So according to the CDC, there have been massive outbreaks of bird flu among chickens worldwide, which is driving up the prices of eggs. Bird flu has also been detected amongst cows and more than 200 other mammals. There have been 15 human cases of bird flu in the US this year, 10 after exposure to infected poultry, 4 after exposure to infected cows, and 1 with no immediate animal exposure, which raises the concern of human-to-human exposure. How worried should we be? Is it safe to drink milk and eat eggs and chicken and beef? And can the virus be transmitted human to human? And is there a vaccine for bird flu?
Well, in terms of how worried we should be, if you're in public health or a scientist studying influenza, I would be really worried. If you're a member of in the general population, I wouldn't be really worried at all. What I mean by that is influenza is really a concerning infectious disease. We had 3 pandemics in the 20th century. I really thought that the next great pandemic of the 21st century was going to be influenza. And of course, it turned out to be COVID. So we've got a lot of viruses to worry about. But the reason why I don't think the public needs to be terribly worried about it is because the currently circulating H5N1 strain of influenza that we're seeing in cattle, humans don't have receptor sites for this particular virus. What the worry is that could this particular virus recombine with a humanized influenza virus and then be able to attach to our receptor sites? We're not seeing that to date. In terms of is it safe to drink milk or eat eggs, chicken or beef, the answer is yes. We have very good studies showing pasteurization works quite well. We haven't seen any problems with eating eggs or meat. Beginning actually next week, the FDA is going to be doing more studies on meat, but as long as the eggs and meat are cooked, people need not worry. And the same thing for chickens. So there's not a worry there, unless, of course, you're drinking non-pasteurized milk. There is the possibility of transfer. We haven't seen that, but there is the possibility. But there is the certainty that there's an awful lot of other pathogens that can make you terribly sick from drinking non-pasteurized milk. In terms of can the virus be transmitted from humans, I was talking about those receptor sites, but we have this tantalizing case in Missouri of a man who didn't have any kind of contact with any of the risk factors for getting H5N1, contact with cows, for example, or birds, et cetera. And then we heard about his partner who also had very mild symptoms. The original case, the index case, was admitted to the hospital, but was discharged, apparently was not very sick from influenza. So that case still has a question mark attached to it. In terms of how deadly is this particular strain, we don't know because it hasn't caused disease in humans to any extent. We've seen some cases of conjunctivitis. We've had a total of 15 cases in humans. Conjunctivitis has occurred. One or two people have had some cough with it, but no one's been terribly ill with it. Again, we worry about this virus becoming humanized and causing more widespread disease, though. So how deadly is it? When you read about a 50% mortality rate, that's based upon other highly pathogenic avian influenza strains. And that data is quite skewed because of ascertainment bias. And so I think we really don't know the morbidity and mortality to those other influenza strains, but we know it's very significant.
And Peter, another infectious disease that's been on people's mind is Mpox. So just this year alone, over 20,000 cases, 600 deaths have been reported in Africa, 96% of which have been in DR Congo. Since 2022, there have been 32,000 confirmed cases of Mpox and 58 deaths in the US. How worried should we be? What causes Mpox? Can you also explain the difference between clade 1 and clade 2?
Yeah, so a complex and evolving topic that, makes me go back in history and in time. So in the 70s, humans started getting Mpox. That's the OG clade 1. And then in 2022, we saw more than 100,000 cases in more than 100 countries of another kind that was less severe, that's clade 2. And Mpox in general is a DNA virus. It's thought to be the less deadly smallpox. And that's important because cases started going up in the Democratic Republic of Congo and other West African countries in the 80s after smallpox vaccination ended. So here we are having these two clades in general. Clade 1, you kind of go in the forest, you get, you interact with one of the reservoir animals, rodent or other to get it. Clade 2, sexual networks, it evolved in that way. Mainly men who have sex with men. And then what happened since the fall of last year is clade 1 mutated. It became clade 1b. So clade 1b has features of both clade 2 and clade 1, which means that there might be a little bit of household transmission, interacting with animals, but also in sexual networks. So that's why it's, people are a little bit on edge because it's evolving. So far, like you mentioned, 13 African countries, including some where it hasn't been there before, like Rwanda and Burundi, etc. Also in Sweden, also in Thailand. It's just a matter of time before it comes to the US. But, whether or not we'll see the same kind of mortality, which is one of the differences, clade 1, 5% mortality in adults, 10% in kids, clade 2, less than 1%, mainly in people with HIV uncontrolled, remains to be seen. In the meantime, we have a lot of vaccines in the developed world. We need to continue to funnel them to the countries that need it the most. We need to funnel diagnostic tests as well. But there's also civil conflict that is threatening our disease control efforts in Africa.
And what are the symptoms for Mpox, and also who should get the vaccine?
Yeah, so about 7 days after you get exposed, which is really intense skin-to-skin contact as far as we know. So you can't get it on Muni or doing Bikram yoga or anything like that, which are some of the questions people ask me. You get flu-like symptoms, mainly fevers, headache, muscle aches, maybe some swollen lymph nodes. A few days later, almost 100, pretty much 100% of people get these boil-like rashes. You've seen them in pictures. They could be quite disfiguring on the face, in the general area, depending on the clade. And they last for a while, so like 3 weeks. So it's not like 5 days and you're done like COVID. They could be very stigmatizing. They could be, it marks you as having something like the scarlet letter, like Kaposi sarcoma and HIV. And that's how we characterize Mpox. Clade 1, you can get up to 1,000 lesions. Clade 2, what we saw in 2022, not as many lesions. But that is basically how it shakes out. And who should get the vaccine? Right now in the US, men who have sex with men, it is in the official CDC recommendations. Those who have had an STI or anticipate having one, which is a big, broad category, and 2 vaccines separated by 28 days. Only about 25% of people who got 1 shot have gotten the 2 shots. And the UK has just recently ordered a lot of other vaccines for a very similar population, but also including healthcare workers who might be at risk.
Thanks, Peter. Let me bring Sarah into this conversation. So, Sarah, let's talk about measles. So there have been 13 outbreaks of measles this year in the US, totaling about 234 cases. Globally, there are an estimated 9 million cases of measles with 130,000 deaths each year. What are measles? How dangerous is it? How's it spread? And why has it been going up despite the availability of inexpensive, effective vaccine?
So measles is an infection that, like COVID-19, is caused by a virus. And also similar to COVID-19, measles is most commonly spread by the airborne route, so when an infected person coughs. I think measles is a disease that most people in the US are really familiar with and think of it as a disease of the past because it used to be a very common childhood disease. And almost everyone used to contract measles by the time that they would reach adulthood. But I think what many people don't appreciate is that measles is not always a benign illness. So before the onset of the vaccine, the estimates really vary depending on the location in the world, but let's say maybe around in the US, 3 out of 1,000 people with measles would die from the disease, and 1 out of 1,000 would experience neurological complications that could cause deafness and sometimes intellectual disabilities. There are and were parts of the world, though, where measles mortality was much higher, and it could be up to 10% of infected people. So before the vaccine, there would be epidemics every few years where 3 to 4 million people would die worldwide from measles. So that's actually more than any single infectious disease agent causes today in terms of mortality. Measles is on the rise again globally for 2 reasons, or maybe a few reasons. So one of them, and particularly in wealthy countries, is vaccine hesitancy. So people afraid that the vaccine will have, unintended consequences, and they don't vaccinate their kids. There has always been a more difficulty in lower income countries with vaccine access, although really the global public health community has done a pretty good job of getting vaccines into lower income countries. During COVID-19, there was disruption to vaccine access, and that is in part what's caused this surge of measles cases around the world, in addition to vaccine hesitancy, also not just in wealthy countries, but also spreading around the world.
Okay, so let's talk about vaccine hesitancy, and so much of it is driven by the idea that vaccines like MMR, which contain vaccines for measles, but also mumps and rubella, could cause autism. Now, we promise our audience that we're going to provide the most accurate, credible, trustworthy up-to-date information. Can you address this question? Does MMR vaccine cause autism?
So MMR vaccine does not cause autism. I could talk a lot about this, but I want to keep my answer relatively brief, just so it can be more impactful, perhaps. So the idea that this vaccine might contribute to the development of autism, it came from a single study that was published in 1998 in The Lancet. So this got a lot of coverage. This idea spread around the world. A lot of people became afraid of vaccination because of this study. After that, there has been a lot of work from people trying to replicate that finding, and there has been no well-conducted, credible study that has reproduced the finding that the MMR vaccine or any vaccine is linked to autism. Subsequently, also, there have been investigations by journalists into, the authors of that paper, and there have been pretty credible allegations that the original study was fraudulent and perhaps conducted for financial gain.
Thank you, Sarah. And let's also talk about polio. So last week, WHO, the World Health Organization, started vaccinating hundreds of thousands of children for polio in Gaza in response to the first case of polio there in 25 years. There hasn't been a case of polio here in the US. It's caused by the virus since 1979, after mass vaccination began in 1955. And the Global Polio Eradication Initiative has succeeded in eradicating polio by more than 99% globally. So why did the WHO decide to go into a war zone and vaccinate hundreds of thousands of children after one single case of polio?
Well, first, let me start by talking a little bit about polio. Polio is also caused by a viral infection, and in this case, the virus is most often spread through the fecal-oral route. Most cases of polio are relatively mild, but 1 in 200 cases results in paralysis. So the situation in Gaza is concerning for many reasons. First, prior to the detection of this single case of poliovirus had actually been found in sewage in Gaza, suggesting that it is circulating more widely there. And this is not at all surprising, given the total breakdown in water sanitation systems that's occurred as a part of the war that's ongoing there. But second, given that the case of polio that was identified was a case of paralysis, it's likely that there are at least 200 other cases that were not detected because they did not result in such severe symptoms. And so because of the risk of polio infection and the likelihood that polio is circulating in Gaza, it really is essential to get in there and vaccinate to prevent the spread. Because I think one of the things that we've learned is, not only do we want to protect the children in Gaza, but infectious diseases don't know borders, and they spread. So it's really important to get on top of polio, which still is one of the public health successes with vaccines, but we want to keep it that way.
Thank you so much, Sarah. Eva, let me bring you into this conversation here and talk about your favorite topic, which is mosquitoes and diseases caused by mosquitoes, which include West Nile, dengue, chikungunya, triple E, and malaria. And I think you have something new that you want to make sure that we talk about with the public. So let's start with West Nile, which is the leading cause of mosquito-borne diseases in continental US, with 491 cases reported this year, including Dr. Fauci last month. So what's West Nile? How worried should we be in California? And is there a vaccine or treatment for it? Eva, you're muted.
Yeah. So West Nile virus, it's a mosquito-borne virus, and it causes disease in humans, actually accidentally, horses and birds. And it spreads to people through the bite of an infected mosquito, especially the Culex mosquitoes, for those of you who are mosquito lovers and into the details about mosquitoes. But it can make people sick, for instance, headache, body ache, joint pain, vomiting, diarrhea, rash. The fatigue can go on after for a while, but can also, in certain people, go on to have serious cases with neurological effects. And it's actually, including death. And unfortunately, there is no vaccine in humans. And essentially it's just, there's no treatment. So it's really up to clinical management. It actually is common in the United States, and this year has been reported in 43 states, with 452 neuroinvasive cases. And in California, it actually is a problem that's here to stay. There's 51 cases, including 6 fatal, that have been reported in California. And the way one can identify if one way is through dead birds, because especially corvid birds and certain other species die when they are infected. And so when West Nile first spread across the country, there were just like entire areas that were wiped out of their crows, for instance, and ravens. So one of the ways that public health uses is having these sentinel chickens that are sent. So they're like flocks of chickens, and then they will capture essentially they'll be it's kind of the canary in the coal mine. And so that's like one way to see. And also mosquito samples are collected. 1,654 to be exact have been collected and tested for the presence of virus in California. And there have been 17 counties in California with human cases, including 13 new positive cases in California last week. So it is around, and the best way to prevent this is to really avoid getting bitten by mosquitoes, avoid standing water like bird baths in your home. Like, don't let the water stagnate, don't let it be there for a long time, because those cute little things going like this in your water are actually mosquito larvae. And they're not so cute, actually. So make sure to avoid that. And you can also, they say there's dead birds are one way of tracking, and you can actually help the California Department of Public Health track West Nile by reporting dead birds. And so there's actually like websites for that.
Thank you. And then there's dengue, right, which is what you've been working on for decades. So
Yeah.
last month, WHO published a report identifying more than 30 pathogens which could trigger the next pandemic. Dengue is on that list, along with bird flu and Mpox. So, Eva, tell us about dengue and the disease it causes. Is there a vaccine or treatment for it? And why did it make it to WHO's list of pathogens with pandemic potential?
Well, partly because I was chairing that. Seriously, I was a co-chair of the flavivirus. I fought hard to get the flaviviruses up on those lists, and they deserve to be, because they have been responsible in general. I'm talking about dengue. You've probably heard of Zika, including also yellow fever and others that and West Nile are all mosquito-borne diseases, and they're actually what's called flaviviruses, which is our particular group. A genus of the viruses that are transmitted by mosquitoes. And the problem is that these mosquitoes are extremely widespread in especially urban areas. And also we've now found with recent research, very widespread in rural areas as well. But they are very pernicious to human habitats, and they breed in clean water around your home. They're called Aedes aegypti mosquitoes, and also the tiger, the Asian tiger mosquito, Aedes albopictus. And they actually, the reason they're tigers because they have little black paws or legs with white stripes. So you can actually find out when you squash a mosquito if you actually have been bitten by one of these. So look for the tiger stripes. But no, seriously, it's very important because there's a huge number of cities that have Aedes aegypti in them, and populations as the disease spreads that are susceptible to the virus and can have giant, 50-60% of the population in the space of a couple months be infected. The problem with dengue is that it is a very abrupt onset of febrile illness, so high fever really quickly, and then it lasts about 3 days, 4 days, the fever, and then the fever goes down. After the fever goes down, there's what's called the critical phase, which is days 4 to 6, when perfectly healthy people can go into shock and die in 24 to 48 hours. And the problem is we don't know who those people are. And so, there are comorbidities, but being healthy is actually almost a risk because you can have an over-exuberant immune response. And so it's very important to stay hydrated, and also to keep a watch on, especially after your fever goes down, especially if you're in an area that's not used to dengue, to be monitoring using, going in and getting labs done on what's called a complete blood count to monitor your hematocrit and your platelet levels. Because if your hematocrit goes up and your platelets go down, that's a very dangerous space for dengue. And there's not enough people who, especially in areas where it's not endemic, that can control, that know how to manage it. And this is a disease that has has a vaccine that's problematic, but we can talk about that later, and no treatment. And so it's really clinical management. And so essentially there can be like a 0.2% case fatality rate if you're in a place that manages it well, but it can be up to 30% in areas that don't. So it's very important to know yourself about how to treat it. One thing I just want to mention is that there's 4 flavors or serotypes of dengue, and it's a very curious disease because generally you think, oh, I got sick, now I have an immune response and that will protect me. Well, it can, but that same immune response can also make your next infection worse and even more severe. If it's a different flavor, a different serotype. So this is called antibody dependent enhancement, and there's a lot of work around that to make sure that the kinds of vaccines that we now are registering are going to be, safe, and that that we'll use our knowledge to make better vaccines in the future.
Right. And chikungunya is also on that list of infectious disease with pandemic potential. So can you just tell the audience what they need to know about chikungunya and how much they should worry about it, right? And while you're at it, I know just right before we came on air, you told me about another infectious diseases that's spreading that I haven't even heard of, which I think it's really important for the public to know about. So if you can talk about that as well.
Yes, certainly. And so there is a chikungunya. I just want to mention also dengue, by the way. 2024 was really a bumper year. It was huge with, tens of millions of cases reported. And so the chikungunya is actually, it's an alpha virus, so it's not the same group of viruses as dengue, but it's also transmitted by exactly those same 2 mosquitoes, and also caused an enormous epidemic in 2014 to 15 in the Americas. Because again, the entire population was susceptible, meaning it had no immunity to this virus. And so it came in, all the mosquitoes were like waiting there, happy to ready to go, and just swept through like all of Latin America, and up to in some cases, in the US as well, especially imported cases. So chikungunya can cause, again, a very high fever. It usually is an acute phase disease, meaning it's over in maybe 5 to 7 days, but is incredibly debilitating, extremely painful, joint and muscle pain like dengue, which is called la quebradora. In fact, it's thought that the first dengue epidemic was actually really chikungunya, but because they both have this very extreme joint muscle pain. And so the problem with chick is, though, it's like arthralgia, and actually almost like arthritis, and that can actually persist for months, if not years, especially in women of middle age. And so that's actually, so it is something to keep an eye on. It's not endemic at all in the United States. But for instance, the countries with the most cases this year have been Brazil, Paraguay, Argentina, and Bolivia. And actually there's some comeback in Europe as well. They had actually, they've been famously a epidemic in La Réunion, which is an island off of Africa, but it's a French protectorate. And so there has been cases back in France and Italy, there was epidemics. And so all of these diseases are actually coming back into regions there they were cleared back in the day. So you will be hearing more. And actually, speaking of hearing more, there is another kid on the block, which is called Oropush. And this is actually a bunya virus. It's a different family, but again, it's transmitted this time by Culex, which is one that transmits West Nile that I mentioned earlier. And this is spreading. It's been endemic in Brazil, but now is really peaking. There are epidemics, especially in the northeast of Brazil, and big epidemic right now in Cuba as well. And so there's one of the issues is that there's more this clade that happens to be spreading now. This, I would say, this lineage, the virus that is spreading now seems to be more associated with neurological disease. It might be more severe, and there are case reports of vertical transmission and potential microcephaly. So everyone's got to watch out for this one to make sure it's not another Zika, and that we are prepared.
And what's it called again?
Oropouche,
Yeah,
Oropouche.
So you heard it here first at Berkeley Public Health. All right, so let me bring Jay into this conversation. Jay, mosquito-borne infectious disease seem to be spreading geographically. For example, of the 8 cases of triple E, that's Eastern equine encephalitis, all 8 are in the Northeast, 4 in Massachusetts, the rest in Wisconsin, New Jersey, New Hampshire, and Vermont, not necessarily what we think of the hotbed of mosquito-borne diseases. How's climate change fueling the spread of these infectious diseases?
So, as you mentioned, this is a really rare mosquito-borne illness. It's one I think that Eva just covered briefly, but it causes neurological problems. So it's quick onset and permanent damage. So why we're so scared about this, first of all, is mortality is really high, about 30% in cases, and then more than 60% of cases have long-term neurological damage. I heard that you can't hear me, so I'll try to speak up. So the virus circulates in a bird mosquito transmission cycle, and there are sporadic infections in mammals, which are typically dead-end hosts. And again, mortality is really high in these cases. That's why we're really concerned about it. So it has a complex ecology, but studies have shown that warmer temperatures can extend the mosquito breeding season and increase their geographic range. So this allows them to carry and transmit the diseases like triple E to new areas. And additionally, changing rainfall patterns can create more suitable breeding grounds for mosquitoes. And so it's much more complex than I'm explaining, because there's also habitat loss. There's also human activity that has a role to play. But the link between climate change and disease transmission for this virus is a major public health concern. And climate models, are still trying to sort of grapple with all the different risk factors, and they've not been able to predict when the virus will be present.
Now, another disease that's spreading, but not by mosquitoes, but by climate change, is valley fever. So, Jay, can you tell us what is valley fever? What's it caused by? How does it spread? How does climate change fuel its spread? And is there treatment or vaccine for it?
Okay, so coccidioidomycosis, or valley fever, it's an infectious disease caused by inhalation of 2 species of coccidioides, that are basically fungi that are found primarily in soils of the southwestern United States. So it's caused by inhaling the spores of these 2 fungal species, and these fungi thrive in dry, arid climates. So particularly Arizona, New Mexico, Nevada, Eastern Utah, Western Texas, and then Central and Southern California. And we have researchers at Berkeley that are experts on this disease. They have papers that are still, that are out right now being reviewed. So really hot off the press papers on this topic, looking at the relationship between climate and valley fever. So it's primarily spread through air. So when wind blows over infected soil, the fungal spores become airborne and they can be inhaled. And so this is why it's more prevalent in areas with high winds and dry climates. So I just want to mention the link to climate change. There was an 8-fold increase in valley fever incidence in California between 2000 and 2018. And we saw valley fever cases in California sharply increase, like basically 2 to 3-fold following wet winters that occur 1 and 2 years following a drought. So basically, it's a little bit more complex than just saying more rain or drought. There are some sequences that we need to see with climate. So yes, rising temperatures and changing precipitation patterns are changing the conditions for the fungus, and in many cases are allowing it to thrive. So we're seeing about 9,000 cases in 2024. We saw a little over 9,000 cases in California.
Wow. And how do we then protect workers who might be exposed? Construction workers, migrant farmers from getting valley fever?
Yes, so you've hit on the most vulnerable population. And let me just step back one important fact. So it's a fairly large disease globally, valley fever. There are about 300,000 people that get it globally each year. Many of them are asymptomatic, but about 40% of those infected get symptoms. So fatigue, fever, joint pain, cough, etc. So 10% of those infected get severe symptoms in their lungs. Now, the individuals who work outdoors or live in areas with dirt or soil that is not paved over have an increased exposure to these fungal spores. And so they're at a greater risk. And then we also see that racial and ethnic minority groups in the US are overrepresented among jobs requiring greater time outdoors. So agricultural work is the main occupation. So first, we need to focus on awareness, education, as well as training. Those are crucial for workers to be informed about the symptoms, causes, and ways that they can prevent valley fever. And then second, we need to think about engineering and environmental control. So engineering controls would be things like reducing exposures by having people work in enclosed cabs, if they're working large equipment, potentially wearing respiratory protection or avoiding dusty areas in high risk times. And then environmental controls would be helping people minimize the spread of spores. So wetting dusty areas, avoiding work during windy conditions, and proper disposal of contaminated materials. So, and then finally, we would want to focus on proper personal protective equipment. But that's sort of the last sort of element that we want to tackle in prevention.
Thank you. Let me bring Sandy into this conversation, and let's talk about sexually transmitted infections. So the other big news recently is lenacapavir. So Sandy, can you tell us more about lenacapavir and why it could be a game changer for HIV prevention, and how might this be better than PrEP? But first of all, tell the audience what PrEP is.
Sure. So lenacapavir is a medication that's being studied for pre-exposure prophylaxis, or PrEP. And that's a general term that we use when we use a medication to prevent an infection before it happens. So in the case of HIV prevention, we already have PrEP in the form of a daily pill, and we also have PrEP in the form of an injection that's given every 2 months. And both of these current PrEP products work really well to prevent HIV infection when people use those products as intended. So this includes daily adherence in the case of oral PrEP. So there's a couple of really exciting features about lenacapavir, which is a product that is not currently approved yet for PrEP. So the first is that 2 recent really large clinical trials have reported exceptionally strong results for HIV prevention. The Gilead Purpose 1 trial, which was released over the summer, and it was conducted in cisgender women, it found that there were no HIV infections in the group that received lenacapavir. So that's 100% efficacy. And a study that was released last week also had really strong results in a different population. And that study included transgender people and non-binary people. So the second reason people are really excited about lenacapavir, in addition to its efficacy, is that it's only needed every 6 months, and it can also be administered as a subcutaneous injection. So this means there's no daily pill to take, and only a couple of visits would be required every year if you were taking this product. And the fact that the injection is subcutaneous means that it could be administered by lots of different kinds of healthcare providers in lots of diverse settings. So something that our team works on is pharmacy delivery of PrEP. So there's a lot of opportunities here. So if lenacapavir makes it through the regulatory process, it could be available as early as 2025 in the US, and that's really exciting. But the lesson we've learned over many decades with HIV prevention is care is that people need to have access to these products. So we have to make sure that the communities who can benefit from them are able to get them and can also afford them. So that's why everyone's very excited about lenacapavir and cautiously optimistic.
Great. And syphilis is on the rise. So reported cases increased by more than 80% to more than 200,000 reported cases between 2018 and 2022. Congenital or newborn syphilis has also increased by about 1,000-fold in the past decade. So what's going on? Why is syphilis on the rise, and what can we do about it?
Yeah, this is really becoming an urgent public health issue. So these trends that you've described are really reflecting a decades-long rise in syphilis that is now becoming a bit of a crisis. And there's a couple of interconnected factors that are behind these trends. So in general, many sexual health programs have been deprioritized and underfunded over decades, and especially during COVID. And the consequence is that we see that people have reduced or delayed utilization of sexually transmitted infection outreach, testing, and treatment services. And this can also lead to a lack of education about STI. And when I say STI, I mean sexually transmitted infection. People have a lack of education about prevention and control measures. And of course, whenever we're talking about sexual health, stigma is a really important issue. That can be a deterrent for people getting receipt of comprehensive sexual health services. So congenital syphilis is a very severe, disabling, and life-threatening infection in the infants of people who were infected with syphilis but were not fully treated. And the increases that we see in congenital syphilis are mirroring the increases that we see among adults, among people of reproductive age who are women or who are other people who might give birth. So in addition to all of the barriers I mentioned, another contributing factor related to the rise of congenital syphilis is inadequate prenatal care. So this means this can be related to reduced screening for STIs during pregnancy, and it can increase the risk of onward transmission. And one study has reported that 2 in 5 infants with congenital syphilis in the United States were born to people who did not receive any prenatal care. So what do we do about it as public health professionals? And much of that is to take action outside of the sexually transmitted infection clinic. So what we need to do is increase access to and engagement with prenatal care among pregnant people. So we might consider any health encounter that occurs during pregnancy, whether that's in an emergency room, in jail, at other maternal and child health programs, as an opportunity to screen for syphilis. We also want to ensure that screening recommendations are implemented. So in California, pregnant people should be screened for syphilis at least twice during pregnancy and then again at delivery. And then, of course, we need to continue to advocate for sufficient and sustained funding for STI programs at all levels of the government.
Thank you. Sandy, is there a morning after pill to prevent sexually transmitted infections from unprotected sex, the same way that we have morning after pill to prevent unintended pregnancy?
Yes, so in certain populations, the U.S. Centers for Disease Control recommends the use of the antibiotic doxycycline for post-exposure prophylaxis to prevent bacterial STIs, and we call this DoxyPEP. So DoxyPEP is essentially taking a dose of doxycycline as soon as possible, but within 72 hours after oral, vaginal, or anal sex. And DoxyPEP should be implemented in the context of comprehensive sexual health counseling and services. Now, right now, CDC only recommends that healthcare providers discuss DoxyPEP with gay, bisexual, and other men who have sex with men and transgender women who've had a history of a bacterial STI in the last 12 months. So that's the group that is being engaged with this opportunity, this public health intervention right now. It's currently not recommended for cisgender women. A recent study in Kenya found that there was no effective DoxyPEP on the incidence of STIs in women in Kenya, but this is probably due to adherence. This is probably due to them actually using the product as intended. So the jury is still out on whether there'll be expansion of populations who can benefit from DoxyPEP. But we have learned, like, again, a lesson we learn often in sexual health is that adherence is really important, and that people are enabled and supported to use products as they're intended so that we can see the maximum public health benefit.
Thank you, Sandy. John, the University of California requires all incoming students to show proof of immunity against measles, mumps, rubella, varicella, or chickenpox, Tdap, flu, and meningitis for those under age 21, as well as TB screen. So what is meningitis? What's it caused by? How does it spread? And why is it important for college students to get their meningococcal vaccine?
Well, first of all, good for the University of California for requiring all of that. The UCs didn't always have those requirements. Meningitis is a very, very serious inflammatory process of the structures that line your brain. And it can be caused by a variety of microorganisms, but especially bacteria. And when we talk about bacteria, one in particular, what's called Neisseria meningitidis, or the meningococcus, is particularly common in certain age groups, like very, very young children, infants really, less than 1 year of age, or people over 85. But another particular group that really has a lot of meningococcal disease are adolescents and young adults between the ages of 16 and 23. And included in that are first-year college students living in residence halls. We see a lot of cases of meningitis occurring there. And that's one of the reasons why this particular vaccine is recommended. And I say this for particular vaccine, but it's really 3 vaccines that we have that can prevent meningococcal disease. And there are differences between them that are important. One of them covers most all of the what are called serogroups or types of the bacteria that cause disease. Others are more selective, but they really are very important for families to consider having their children vaccinated against this bacterial infection.
Thank you, John. Jay, antimicrobial resistance has been called the silent epidemic, or the silent pandemic, actually, with an estimated to cause 1.3 million deaths globally every year. So that's about the same for TB and more than HIV and malaria combined. What are some novel approaches to treating antimicrobial resistance, and what must public health do to prevent it?
So thanks for that question. For the first part of the question, there are new antimicrobials at different stages in the pipeline for approval and testing, and they're going through randomized controlled trials to test these. But in terms of more novel approaches, there's phage therapy. So we use these viruses that infect bacteria. Sorry, I still am getting a message that it's hard to hear me, so I apologize. I'm going to speak up and maybe yell. I might come across as though I'm a coach rather than a researcher. But so we use bacteriophages, which are viruses that infect bacteria, and they target specific bacteria without harming human cells. So that's kind of an exciting area for treating drug-resistant infections. Next is probiotics. You could think about poop transplants or fecal transplants, so introducing beneficial bacteria that hopefully, for fecal transplants, they do quality control to make sure that it's only healthy bacteria that are being delivered, but we deliver those to the gut. They end up out competing other harmful bacteria. And then there are things like nanotechnology, where we're using nanoparticles to deliver antibiotics directly to infected sites, and even sort of immunotherapy, where you're beefing up people's immune system and allowing their immune system to fight infections more effectively. So that's sort of on the treatment side. On the prevention side, there's so much more we can do. We are using antibiotics inappropriately in the United States and across the globe that we feed to food animals. So these are livestock that we consume. Over 70% of the antibiotics in this country go for livestock. So that's an area that we can greatly improve for prevention. There's also just primary prevention, improving water supply, sanitation, hygiene, infection prevention and control in hospital settings. All of those sort of primary prevention modes would greatly reduce the spread of these organisms. And then, of course, there's promoting vaccinations. We have a researcher here, Dr. Leonard, has shown great reductions in mortality and infections just based on increasing vaccinations and then developing new antibiotics and then improving stewardship of antibiotics.
Thank you, Jay. Sarah, let's talk about your favorite disease, a disease that doesn't get talked about enough, which is TB or tuberculosis, which remains the leading cause of death from infectious diseases worldwide, rivaled only recently by COVID, killing more than 1.3 million people each year. And yet we hardly ever hear about it in the news. Why has it been so hard to eradicate TB? What is the latest on the development of a vaccine for TB?
First of all, I really want to thank you for asking this question because, like you said, TB is really one of the most important pathogens for global public health. During the COVID-19 pandemic, it's estimated that actually more people died from TB than from COVID-19, but it's really not talked about very much, at least not in the United States. So TB is a very different disease than the ones that we've been talking about. We've been talking mostly about viral infections. You get infected and you can have severe consequences, but generally you either resolve the infection, or you don't. TB is different. So what happens is that people are thought to get infected very early in life, and then the immune response is able to control infection, but not eliminate infection. And so we have this huge reservoir of people who have TB, but they don't have active signs of disease. It's probably 2 billion people have TB. 10% of these people will have active disease at some point. But the problem is we have no idea of predicting who that will be. So complicating this is the fact that there is no effective vaccine for TB, that treatment requires a patient to take multiple drugs over a period of weeks to months, and sometimes years if they have drug-resistant TB. Compliance with these regimens is a huge issue because these drugs are not amazing. They don't make people feel good. You feel sick when you're on these drugs. It's really hard to take drugs for weeks to months, and so people stop taking them, and this has led to the rise of drug-resistant strains. So there have been actually in the last few years some really positive developments in the field of TB in terms of vaccines and antibiotics. So we've seen the introduction of a small number of new drugs for treating TB and new treatment regimens. And so this has allowed physicians to shorten drug treatment times for TB, for uncomplicated infection, for example. Whereas once upon a time, you would have had to take, several drugs for 6 months. Now that has been shortened to as short as 3 months. There are also new avenues for treating patients who have infections with drug-resistant bacteria. And so there are these hints of, if we look for drugs, we can find them and we can continue to combat this disease. However, there aren't enough new drugs in the pipeline, and we need a lot more momentum around new antibiotics. So actually, just a few years ago, for the first time in decades, there was hints of efficacy in a new vaccine that was tested in people. And so what we saw with this vaccine was that there was protection in 50% of people over 3 years from developing active disease. So there's a long way to go, but it tells us that developing an effective vaccine is possible. And so I think for the first time, I've been working on TB for 20-something years, and I really do feel that for the first time there's some light on the horizon, and there's a lot of room to really make improvements.
And what are some of the latest breakthroughs in terms of our understanding of the immune system, and how can we leverage these advances to innovate vaccine development or treatment of infectious diseases?
Yeah, so this is a really exciting time to be an immunologist because people have made a lot of progress in understanding how the immune response underlies many diseases and how we can get the immune response to fight diseases that we normally don't think of as involving the immune response. And so one example I want to talk about today is cancer. So people have made a lot of progress in understanding why tumors develop. So it turns out that the environment of a tumor, it turns off our immune cells so that cells like T cells that could normally come in and recognize a tumor cell as something, that shouldn't be there and kill it. The tumor creates this environment where the T cells are inhibited, other cell types that could participate in the immune response are inhibited. And so that allows the growth of these cancers. So maybe people in the audience have heard of some of the kind of revolutionary breakthroughs that have developed in the cancer field in the form of checkpoint inhibitors, which actually originated from basic science discoveries here at Berkeley, where we can now, people can now give these inhibitors that unleash the immune response to recognize the tumor and eradicate the tumor. And one of the really cool things about TB is that TB is a chronic infection. It's kind of like a tumor in a way. And the environment of TB, we now know, also shuts down the efficacy of immune cells and prevents them from doing their job. And so one of the things that is exciting in the TB field is, can we take some of the lessons from cancer and apply them in the context of TB and other chronic diseases?
Thank you, Sarah. Well, let's take some questions from our live audience. Elise, are there any questions?
Sure, yeah. I mean, we have some questions about RSV and COVID. One question was, is there still a shortage of RSV vaccines? And somebody is remembering when there was a limited supply earlier this year available to infants.
I'll answer that. There's no shortage. It's plentiful. You can just get online with CVS or Walgreens or whatever, and you should be able to get it.
Great. Elise, next.
Right. And there's actually, there aren't that many other questions. So I encourage the audience to ask questions now if they want any answered live. But someone else is asking how long the current COVID vaccine provides protection from the virus.
I can take that one. So in general, it will be a year, and that's why the interval is a year for most people. There's a discussion about whether or not some people, like very immune compromised individuals, would need it more frequently. In fact, they're allowed to get it every 2 months if they wanted to. And the same for those who are older than 65. But once a year for serious disease. And then the bonus is, if it resembles what's circulating, you can actually lower your chances of infection by about 6 to 8 weeks. That's why Dr. Schwartzberg says get, a lot of the vaccines in October, because if you add 8 weeks to that, that's kind of like a lot of holiday events.
And somebody has a sort of a follow-up to that. And so if you do have a COVID infection, how long do you have immunity afterwards if you do?
Go
I
ahead,
would say
Peter.
most people, sorry.
No, I just said, go ahead, Peter.
So what we know is that you have a force field for about 3 months. So it wouldn't make sense for you to get the vaccine within that time. But, it probably lasts about the same, but it's unreliable. It depends probably on dose and circumstances. So that's why the recommendation is not to rely on infection acquired in the community, but to rely on vaccine, which is very standardized, and we understand what protection you're getting from it.
All right, now that the floodgates are open, here's a question that's about tuberculosis. Globally, are there any breakthroughs or emerging areas in TB diagnostics, especially for antibiotic-resistant cases, particularly mono-resistant to INH?
Yes, so there have been actually lots of breakthroughs in diagnosing drug-resistant bacteria. And actually, I just came from a talk today, right before this event, where I heard from a researcher at the University of Washington who was working together in partnership with people in Kenya to develop new point-of-care diagnostics that can identify a larger range of mutations that cause resistance to drugs in TB right there, cheaply, easily. And it looks like it's working really well. So that's just one example of many. I think there's been a really exciting kind of influx of people who know a lot about diagnostics and thought a lot about it more during the COVID-19 pandemic. And I do think that TB and other diseases are benefiting from that.
And Sarah, maybe another question for you. Somebody says, I noticed that Medi-Cal covers the BCG vaccine for TB. What does that do and who would get it?
So BCG is really not required for people who live in places where the rates of TB are low, like the United States. BCG is not really effective against the primary manifestation of the disease, which is adult pulmonary tuberculosis. But BCG can protect young children from getting severe forms of the disease. And so that's why in places where the rates of TB are high, BCG vaccination is still universal. Because if you can protect some kids, then of course you want to, but it doesn't seem to have made an impact on kind of the adult pulmonary TB in most parts of the world.
So the floodgates are open with questions, and here's an interesting one. What unexpected non-health sector should be prioritized during the early response to a pandemic of any sort to ensure a more resilient and comprehensive strategy? And then the same person is asking if our panelists could delve into the factors that have contributed to the prevalence of vaccine hesitancy.
I can take the first part of that one with to throw out an idea, which is that I think we greatly underestimated during the COVID-19 pandemic how important it was to get ahead of the media conversation and health communications with the public. And so I would say if we went through this again, I think from day one, we would engage with our health communication partners better to be able to not only kind of share what we're learning on the scientific front, but to be able to do that in a way that's accessible to a lot of different audiences.
Is anyone interested in talking about vaccine hesitancy?
Well, I've been teaching for 6 years an entire semester course on vaccine hesitancy and resistance. And I've got to say that by the end of the course, I still don't have a good answer to this. It's a terribly frustrating problem. The question that Michael asked earlier about does the MMR vaccine still does it cause autism? Well, that question shouldn't have been asked because we've answered it as we heard earlier. We've answered it with very good data that there's no association. So vaccine hesitancy and resistance has a lot more to do with very complicated psychology. And I don't think we have time to do that right now because I don't even have time in a whole semester to do it.
John, I had a question for you around that, which is, given that it seemed to go with certain states or certain political persuasions, what is the impact of, the political climate on vaccines in particular, in your opinion?
Well, I think we had a very difficult time early in the pandemic in regards to the messaging from our government regarding vaccines. And it really fostered a lot of misinformation and disinformation, both directly and indirectly. I'm going to give a tangential answer to your question. This July, so 2 months ago, the House of Representatives passed an appropriation bill that slashes the CDC funding by 20%, that eliminates the Agency for Healthcare Research and Quality, and that radically restructures the NIH. Now, this has got to go to the Senate to be passed, and hopefully it won't, and it certainly wouldn't be signed by the current president. But I think that that's an illustration of the kind of thinking that we're trying to combat, and that doesn't directly address the issue about vaccine hesitancy, Peter, but it indirectly really does when you send messages like this.
Thanks, and maybe I will take one more question from the Q&A, and then Michael, I know you have a few ending questions. Somebody has a question about avian flu. They're asking if the agricultural industry is obstructing access to education, prevention, and vaccination to farm workers. And sort of on the flip side, what is the agricultural industry doing to protect workers in that field?
Maybe
Well, I'll start, but I'd love to get other answers to that. The USDA is responsible for promoting the agricultural industry in this country and assuring the safety of agricultural products for the American people. Sometimes those two things go in parallel, but too often they are diametrically opposed, and that really creates problems. So the USDA has been somewhat, particularly early on, feckless in terms of its approach to this avian influenza problem. And the agricultural industry, through the eyes of people owning dairies, you can certainly understand why you wouldn't want to see an epidemiologist from the CDC coming in and wanting to take swabs of the udders of cows and the nasopharynx of their workers. But it is very unfortunate that we don't have a more cooperative agricultural industry to work hand in glove with public health. And just I'll conclude by saying that, this country did a lot of China bashing for the COVID pandemic and the open air markets, and criticizing China for not doing more with their open air markets. Frankly, we're not doing an awful lot with our agricultural industry with H5N1. I'd love for other thoughts by the panelists.
I'll just add that our food animal production system is designed in a way to facilitate the spread of these kinds of infections. One, because the animals are crowded together and chickens get less than 1 square foot. They live in a very unhygienic environment where they would rather throw pharmaceuticals like antibiotics at the problem rather than take on hygienic practices. And that's partly because the companies have the economic screws so tight on these producers that are actually sort of raising the animals to production. And then second, the farmer is responsible for waste management, and they do not have the resources to properly manage that waste. So it goes into the environment untreated. And so this is a fundamental sort of design flaw that really augments the spread of these kind of infections.
Elise, let's go and take a couple more questions because I'm looking at these questions and these are really great questions.
Sure. Well, so a question that just came in is sort of asking about antibiotic use in farm animals and antibacterial resistance, how that is linked together.
Yeah, this is something I've been studying a long time. I think, we're getting closer and closer to understanding directionality of movement, but we do know that any antimicrobial use provides a selective pressure to develop an environment for these bacteria to thrive. And these specific genes that sort of enable a bacteria to be resistant to the drugs helps them to spread to bacterial populations. So the evidence is getting stronger and stronger, but sometimes industry wants to really be able to link a specific bacteria to a specific farm or practice. And it's very difficult to do with bacterial populations. So that's kind of where the work is at this point.
If I could just jump in to tie a couple of things together, because I also mentioned doxypep, which is the use of antibiotics after sexual exposure to prevent bacterial STIs. And the main concern there is also the development of antibiotic resistance. And there's not a lot of evidence that that's going to be a significant issue yet, but it's something that we're very worried about with this new public health innovation.
Thank you. Going back to COVID, a person asked a very practical question, which is they already got their COVID shot and their flu shot for the year, but then they heard, maybe they should have waited a few weeks. Should they be worried about early 2025, or not? And Maybe Peter or John could take this one.
I can start. You shouldn't be worried at all. The main superpower of the vaccine is prevent hospitalization and serious disease. And to me, infection prevention has never been the goal of the vaccine, but it's kind of a nice bonus. But again, I wouldn't worry about it because you'll be well protected in general. The exciting thing is you got the vaccine, which I'm really excited about.
Thank you. And then this is a more, it's a much bigger question. What are the prospects in general, or in particular, for rapid diagnostic methods that capture pathogen genotypes for wide-scale epidemiology, especially of new and emerging diseases?
I mean, I guess I can say that there are now techniques that are in use that we kind of collectively refer to as metagenomics, where you can go into a patient sample and use new sequencing technologies to identify everything that's in there. So you don't have to know what you're looking for ahead of time. You can just see what's there based on sequencing. And many times that's something that you know or you expect, but sometimes you find something unknown.
Thank you. Anyone else, or should I go to the next question?
Before you go to the next question, I'm going to wrap up in a little bit with the lightning round. So the two questions for y'all to address in less than 30 seconds each. What one piece of advice would you have for our audience to keep themselves safe and healthy? And what's that one thing that public health must do to be better prepared for the next pandemic? All right, so at least ask your last question and then we'll do the lightning round.
All right, this is a very specific question, and maybe somebody knows the answer. I recently saw a preprint that talked about the development of LNP mRNA vaccine for MTB. Can you please talk about this?
For MTB?
Yeah.
Oh, yeah. So with the success of the mRNA vaccines for COVID, I think people got really excited about the idea that maybe these vaccines are kind of a magic bullet or a silver bullet for many, infectious diseases. One thing that's important to keep in mind is that we know that the mRNA vaccines for COVID are good at eliciting protection against an infectious disease when what you need is a neutralizing antibody. And we know that with TB, that is not the answer. So it is possible that mRNA vaccines will have efficacy against TB, but I hope that's true, but I'm not holding my breath.
All right, with that, let me go and wrap this up. So lightning round, 2 questions. What's one piece of advice you have for our audience to stay safe and healthy from infectious diseases? And what must public health do to be better prepared for the next pandemic? 30 seconds each. We'll start with you, Sarah.
Wash your hands. Same answer I give my daughter and her friends when they come over. Wash your hands. That really is the cornerstone of public health. I mean, the readiness for a pandemic is a really difficult question to answer because, and I think this goes well beyond, the 30 seconds I have. I mean, we need people to not lose faith in public health, and we need more investment in public health infrastructures, but those are not easy things to do.
Thank you. Jay?
I would say don't let down your guard. It's tempting to sort of feel like, oh, we kind of made it through things like COVID, et cetera. But there are times when you can really reduce the risk of infection by putting on a mask in the public transportation system or things like that. So just try to stay vigilant.
And pandemic preparedness?
Since I'm just so focused on antibiotic use, the misuse of antibiotics, I would say we really need to tackle the misuse of antibiotics in agriculture. It's a problem in this country, and it's even in some cases worse in other countries because there are plenty of places where I work, last line antibiotics are being used, and these organisms then end up in the food supply.
Thank you, Jay. John?
Well, I have one answer for both of your questions. That is, elect officials for our government that will be responsible to the public and public health issues.
Thank you, John. Sandy?
I would recommend that people don't have an overwhelming fear of infectious diseases, but I think common public health measures are incredibly important, like hand washing, masking, staying home when you're sick, and engaging in safer sex practices like PrEP when possible. And in terms of the next pandemic, I would say that in addition to what all of my colleagues have said today, I think we need to expect the unexpected and to question our assumptions. I think we had a delay in recognizing airborne transmission of COVID-19, and we really were kind of on the back foot those early critical days of the pandemic. And I think we should learn from that and how to be more open-minded in the future.
Thank you, Sandy. Eva? Oh, you're muted, Eva.
I would say for the first, keep healthy, get some sleep, unlike me, make a strong immune response. This is important. Also avoid and prevent mosquito-borne diseases like standing water, repellents, bed nets, etc. So that's like an important aspect. For the public health, for the next pandemic, I mean, it's really like building strong public health systems and supporting and respecting public health workers. I think that's an important aspect. And I really think it's important also to emphasize in our global health work, the respect and essentially working with our partners abroad to build capacity and equity in country so that it's possible to respond in country to the emerging diseases before they spread.
Thank you, Eva. Peter, I'm going to give you the last word.
That's kind of scary, Michael, but but thank you. First of all, I thought John's one answer to everything would be vaccination, but I was surprised that it was. But anyway, my sort of how to stay safe, I think I agree with everyone. The other thing I would add is I think we can all be activists. And activism doesn't mean you go on a hunger strike or you lie in front of somebody's door. It could mean talking to your legislator, or combating climate change, or having a conversation with the person in the checkout line if they're receptive to listening to you. In terms of preparedness for the next pandemic, I was trying to come up with a mnemonic, and I came up with the 3 M's. So money, we need to continue to fund prevention and public health. We are a very treatment-oriented society, and I think we lose because of that. The second M is, of course, messaging, and I think many people brought up messaging, and I think Sandy in particular, and I think we lost out because of that. And then the third M is merging, but it was supposed to be alignment, but I had to make an M to make the 3 M's, and that means we have to be aligned in terms of one central strategy. We during COVID, we weren't like New Zealand or Taiwan. We had like 50 different plans. So I think we can do better the next time around.
Thank you. And on that note, let me go ahead and close this amazing panel. Please join me in thanking our amazing panelists for such a wonderful virtual town hall today. If you find this town hall informative, go ahead and shoot me an email in terms of what topics you would like us to cover next time. But with that, let me go ahead and just thank all of our panelists, and thank you all for joining us tonight. And please stay safe and be well, everyone.